Acute or chronic pancreatitis. This is dealing with the exemplar of digestion. The priority concepts in this chapter are nutrition and immunity. The nutrition exemplar is cholecystitis. The immunity exemplar is acute pancreatitis. And an interrelated concept is comfort. The pancreas is an endocrine gland that secretes insulin and an exocrine gland which secretes enzymes that become active in the small intestine, and they help with the breakdown of starches, proteins, and fats. These enzymes are normally activated when they enter the small intestine, but if these enzymes activate early, meaning in the pancreas and not the small intestine, we have the development of the inflammatory process of pancreatitis. Acute pancreatitis is serious and it's a potentially life-threatening inflammation of the pancreas. Premature activation of excessive pancreatic enzymes destroy ductal tissue and pancreatic cells and result in autodigestion and fibrosis of the pancreas. In other words, the pancreas eats itself. Severity will depend on the extent of the inflammation and the tissue damage. It can be a mild situation with edema and inflammation, but extend to severe with necrotizing hemorrhagic pancreatitis, which is diffuse bleeding pancreatic tissue with fibrosis and tissue death. There's four pathophysiologic processes that occur with acute pancreatitis. We start off with lipolysis, which is enzymatic fat necrosis by lipase occurring. Fatty acids are released and combine with ionized calcium that leads to hypocalcemia. Then we have proteolysis, which involves the splitting of the proteins by hydrolysis of the peptide bonds. This can lead to thrombosis and gangrene of the pancreas. Elastase causes the elastic fibers of the blood vessels and ducts to begin to dissolve and results in necrosis of the blood vessels. This, of course, will lead to mild or massive bleeding. Many deaths will occur from acute pancreatitis that result from irreversible hypovolemic shock because of this hemorrhage. The inflammatory stage occurs when the leukocytes cluster around the hemorrhagic and necrotic areas of the pancreas. This can lead to a pancreatic abscess, which requires prompt drainage to prevent sepsis. If infected fluid becomes walled off by fibrous tissue, then a pancreatic pseudocyst will develop. A chart of the autodigestive process is found in the next slide. But before we get there, let's talk about complications. They can be severe and life-threatening with acute pancreatitis. They can include hyperglycemia, diabetes mellitus if there's total destruction of the pancreas, pancreatic infection, hypovolemia, hemorrhage, acute kidney failure, paralytic ileus, hypovolemic or septic shock, pleural effusion, acute respiratory distress syndrome, pneumonia, or atelectasis, multisystem organ failure, disseminated intravascular coagulation, DIC, and diabetes mellitus. So what do we see when someone has acute pancreatitis? Well, first of all, let's talk about the causes. It can be caused by trauma, blunt trauma, gunshot, stab wounds, We have a procedure called an endoscopic retrograde cholangiopancreatography, or ERCP, that could potentially cause pancreatitis. Obstruction from cysts, tumors, abscesses, metabolic issues such as hyperlipidemia, hyperparathyroidism, hypercalcemia, renal failure or transplant, gastric or duodenal ulcers, viral infections, alcoholism, which alcoholism as a cause for acute pancreatitis is a pretty common cause, but it is a more common cause in men than it is in women. Drug toxicity, smoking, tobacco, cystic fibrosis, gallstones, which accounts for almost one half of obstructive pancreatitis. And talking about causes of pancreatitis, again, this is very common, and it's going to be more common in women than it is in men. Additional causes, family history, and childbirth. So as we look at this client, the signs and symptoms are going to vary widely and depend on the severity of the inflammation. There is usually severe and constant abdominal pain to mid-epigastric area or the left upper quadrant. This pain can radiate to the back, the left flank, or the shoulder. The onset is usually sudden, and it will be worse in the supine position. These clients may find relief if they curl up in the fetal position or they sit upright and then lean forward. It's really important for us as nurses to help determine the triggers, such as alcohol intake or a high-fat meal. These clients may also experience weight loss, nausea, vomiting. They may be jaundiced. They may have a gray-blue discoloration of the abdomen or the periumbilical area or the flank. They may have decreased or absent bowel sounds, abdominal tenderness and or rigidity, which that would be peritonitis, ascites, elevated temperature, tachycardia, and decreased blood pressure. They may have dyspnea or orthopnea. Psychosocially, these clients may have a potential excessive alcohol intake. So it's really important that we always inquire about alcohol intake to rule out that as being a cause. As far as labs to assess, we're going to get an amylase, lipase, trypsin, elastase, glucose. All of those would be elevated. Calcium and magnesium, which would both be decreased. Leukocytes, a CRP or C-reactive protein. With liver involvement, we would need a bilirubin. The ALT and AST, which would all three be elevated. Imaging, we can look at an ultrasound. We're looking for causes, which may be gallstones. We can get a contrast enhanced CT scan. That would definitely help with diagnoses. Abdominal x-rays, again, may show gallstones. A chest x-ray, which could show elevation of the diaphragm or pleural effusion. An ERCP, again, this is a procedure that is done looking at some of those ducts that could help determine if there are any pancreatic stones. Prognosis, if treatment is early, then mortality is decreased. But mortality will be higher in the older adult and hospitalized clients. If the client has biliary tract disease, then prognosis is pretty good. So usually something to do with the gallbladder or some stones. If the cause is from alcoholism, prognosis is usually pretty poor. Here's that slide that I was talking about. This, uh, the priority hypothesis or priority collaborative problem for any clients that have acute pancreatitis will include severe pain due to pancreatic inflammation and enzyme leakage, weight loss, and inadequate nutrition due to the inability to ingest food and absorb nutrients. So again, this slide shows the process of autodigestion with acute pancreatitis. So what are we going to do? Well, we do need to manage pain, most definitely. We can do some non-surgical management. The primary drug class for pain management will be opioids. Severe pain in mild pancreatitis usually will only last 2 to 3 days, and up to 2 weeks with severe pancreatitis. We may also do some drug therapy. The histamine receptor antagonists and protein pump inhibitors, antibiotics with acute necrotizing pancreatitis or pancreatic abscess would be appropriate. Positioning. Again, if the client lies in the fetal position or they sit with their knees drawn up to their chest, they sit in an upright position and lean forward, that helps with pain. In mild cases, IV fluids, and these will be isotonic fluids. They are going to be NPO while they're in the acute stages of pancreatitis. Again, we're talking about these enzymes beginning to be secreted while they're still in the pancreas. And then it begins that autodigestion period. Well, what causes that release of those enzymes? What causes the release of the enzymes is food or fluids passing through the digestive tract. So we keep the client NPO to prevent passage of anything through the digestive tract and subsequent release of those pancreatic enzymes. If just being NPO does not help with pain relief, we can also place a nasogastric tube. We may need to replace calcium and magnesium, and we definitely need to do intake and output, and potentially we may need that indwelling urinary catheter to obtain accurate outputs. Again, with severe pancreatitis, that NG tube would be a must. Different procedures or surgeries, that ERCP, if we suspect there may be an obstruction caused by gallstones. We could do the laparoscopic cholecystectomy, removal of that gallbladder, or drain a pseudocyst or abscess. It is very important that we promote nutrition. Again, we're going to be keeping these clients NPO and or having a nasogastric tube placed. So nutrition is going to be an issue. So we keep them NPO in the early stages. We're going to provide some antiemetics because nausea is definitely a symptom. They may require the jejunal tube feedings. Enteral tube feedings are definitely going to be preferred over parenteral because there are fewer complications with that. But again, do we want something passing through the digestive tract? Daily weights. If the client is not NPO or when they are allowed to begin eating, then we encourage small, frequent meals that have moderately high carbohydrates, high protein, and low fat. They should also be bland, in other words, very little to no spices. These clients should also avoid caffeine and alcohol, and they may require supplements. With the care coordination and transition management for home care and self-management, that will be individually based, dependent on the client's status. And with evaluation, we have to look at pain control and adequate nutrition. Now, chronic pancreatitis. This is going to be more of a progressive, destructive disease of the pancreas that is characterized by remissions and exacerbations. We'll see inflammation and fibrosis that lead to pancreatic insufficiency and diminished function. There are different categories. It can be chronic calcifying pancreatitis, which is the most common, and it's primarily caused by alcoholism. The inflammatory process will lead to fibrosis of the tissue, calcification, and tissue necrosis. With chronic obstructive pancreatitis, this is caused from spasms and obstruction of the sphincter of Oddi. This is usually caused by gallstones. We may have autoimmune pancreatitis, which is a chronic inflammatory process. This particular category increases the risk of pancreatic cancer. And idiopathic and hereditary chronic pancreatitis. These also increase the risk of pancreatic cancer. Symptoms of chronic pancreatitis include loss of the exocrine function. These clients may experience steatorrhea, which is going to be that pale, bulky, frothy, really odorous stool caused from fat, weight loss, muscle wasting, fat and protein malabsorption. So these clients look like they're starving. Edema of the feet, legs, and hands due to the loss of albumin and loss of the endocrine function. So they may begin to develop symptoms of diabetes mellitus. Pulmonary complications such as pleuritic pain, pleural effusions, pulmonary infiltrates, ARDS, pancreatic ascites, jaundice, dark urine, again, diabetes symptoms, those 3 Ps of polyphagia, polyuria, and polydipsia. Abdominal pain that is continuous, described as burning or gnawing. And potentially we may palpate a left upper quadrant mass. We diagnose this based on the symptoms and the labs. Now understand, with chronic pancreatitis, the body tends to compensate. So labs may be normal or just have a small to moderate elevation. So we may have a normal amylase and lipase, normal bilirubin, uh, alkaline phosphatase, and glucose, or those may be slightly elevated. We can do imaging, which would include a CT scan, an MRI with contrast, an abdominal or endoscopic ultrasound, or an ERCP. So how do we treat chronic pancreatitis? Well, the focus of chronic pancreatitis treatment will be pain management, adequate nutrition, and prevention of disease recurrence. Non-surgically, again, drug therapy and nutrition therapy. These are going to be the primary interventions. So analgesics, we may start with the opioids, but move to the non-opioids when we can. Enzyme replacement. This is going to prevent malabsorption, malnutrition, and excessive weight loss. So think about just something I want you to think about here is when we're giving enzyme replacement, it's to help reduce the symptoms of what we're seeing with this disease process. So ultimately, with the enzyme replacement, we're going to want to see normal pancreatic function. When we give enzymes, though, it's important that we instruct the client to not crush or chew the tablets. They take them with all of their meals and snacks. It's going to replicate the normal enzymatic secretion of the pancreas, which are released with meals, snacks, fluids. Effectiveness will be measured by the frequency and fat content of the stools. We may give those H2 blockers again or the proton pump inhibitors, and these clients may also require insulin therapy. With nutrition therapy, they may require the TPN or the TEN, which would be the enteral nutrition, definitely some vitamin and mineral supplementation, a dietitian consult. These clients are going to require an extremely high calorie diet, 4,000 to 6,000 calories a day. They need high carbs and protein, but they should avoid high fat because it causes or increases diarrhea. And they need to be instructed to not consume alcohol. Surgical management. This is only done for ongoing abdominal pain, pancreatic abscesses, or pancreatic pseudocysts, or they may require a cholecystectomy. As for prevention, they need to avoid triggers, and that includes caffeine, avoid alcohol, avoid nicotine. They need that bland, low fat, high protein, moderate carbohydrate meal, and it needs to be bland, so avoid those spices. Meals should be small and snacks. Uh, all of these should be high in calories. They will require pancreatic enzymes and will probably require frequent rest. So we have a case study. A client presents to the ED the day after Thanksgiving. The client states that about 1 hour ago he experienced a sudden onset of pain in the left upper quadrant that radiates to the left flank area. The client rates the pain on an 8 on a numeric pain scale of 0 to 10. The client is admitted with acute pancreatitis. What lab finding corroborates with the diagnosis of acute pancreatitis? Is it a serum lipase of 150, a serum amylase of 200, a serum glucose of 80, or a white blood cell count of 6,000? The correct answer is serum amylase. In preparing to care for the client, which condition does the nurse recognize as a potential complication of acute pancreatitis? Select all that apply. Is it strep throat, pleural effusion, diabetes mellitus, pancreatic infection, acute kidney failure. Correct answers are B through E. A is the only incorrect answer. When the client is asked about pain, the client states that it is intense and continuous. The client also states that sometimes when he curls up in a fetal position, the pain decreases. Which medication does the nurse anticipate will provide the most comprehensive pain relief at this time? Is it PCA morphine sulfate, ibuprofen, acetaminophen, or oral hydromorphone, which is also known as Dilaudid? The correct answer is the PCA morphine. The client has been NPO but is now tolerating food. What education will the nurse provide regarding nutrition? Small and frequent meals are best. Use of alcohol and caffeine should be consumed in moderation. Expect to experience nausea and vomiting as you begin to consume foods. Low carbohydrate, high protein, and high fat meals should be consumed. The correct answer is A. We're going to want high carbohydrates and low fat. We want there to be no nausea or vomiting. They should not be consuming alcohol or caffeine. The client is now being discharged home. When providing client teaching, what will the nurse include as to when the client should seek emergency care? Uh, Sorry, I just kind of blew through that one. A client with chronic cholecystitis reports pruritus, clay-colored stools, and voiding dark, frothy urine. Which lab analysis is a priority in the nurse's assessment of the client? The lipase level, total bilirubin, liver function tests, or white blood cell count? The correct answer is B. If we have an excessive amount of circulating bilirubin that is usually present with chronic cholecystitis, it's going to be responsible for that itching, that pruritus, and changes in the stool and urine color. Cholecystitis is associated with several risks, including hepatic disease, pancreatitis, and peritonitis. So it's really important for us to monitor liver function, pancreatic lab values, and white blood cell counts. Will be important, but not as important as that total bili level. Which client is more likely to develop gallstones? The 45-year-old Caucasian female with a family history of gallstones, the 55-year-old African American male with a history of diabetes mellitus, a 62-year-old Hispanic Latino female with a history of irritable bowel syndrome, or the 60-year-old obese American Indian female with a history of diabetes mellitus. The correct answer is actually D. Risk factors for developing gallstones include the female gender, obesity, that family history of gallstones, diabetes mellitus, the American Indian and Caucasian descent, a rapid weight change, advanced age. There are Additional risk factors that will increase the likelihood of developing gallstones, um, or these are risk factors, I'm sorry, that will uh, increase that likelihood. In the care of a client with acute pancreatitis, which assessment parameter requires immediate nursing interventions? The heart rate of 105, a serum glucose of 136, a blood pressure of 102/76, a respiratory rate of 28. All of these are acceptable except that respiratory rate. A heart rate of 105, maybe they just walked up the stairs or just walked across the room. They've exerted themselves some way. That serum glucose, it doesn't say if it was a fasting glucose. Maybe they just ate. Blood pressure of 102/76. If this client is athletic, that could be a very normal blood pressure. Um, it is on the lower side, but the more physically fit we are, the lower our blood pressure. But a respiratory rate of 28 is unacceptable. It's usually caused by pulmonary complications of some kind.